Next. Okay, so we talked about the CDC, and just wanted to go over risk factors for severe COVID-19. We talked about age, and the list has been kind of changed since 7 months ago. And there are some more specific diseases that are being mentioned at the CDC website that are really risk factors for severe disease, COVID-19 disease. So cancer, chronic kidney disease, COPD, which is chronic obstructive pulmonary disease, heart conditions such as heart failure or coronary artery disease or cardiomyopathies, all types of immunocompromised states, that basically refers to weakened immune system. Typically, these are patients who have cancer and are taking drugs that suppress the immune system, or autoimmune diseases where immunosuppressive drugs are used. These are the main categories. Being extremely overweight is a risk factor. Sickle cell disease, which is a blood disease, smoking, and type 2 diabetes. These are the ones that are kind of established as risk factor for severe disease. Next. Okay, so there are a list of conditions that are listed as might be at an increased risk for severe disease from the virus. That includes asthma, cerebrovascular disease, cystic fibrosis, which is a lung disease, hypertension, immunocompromised state, like a weak immune system, neurologic conditions such as dementia, liver disease, being overweight, pulmonary fibrosis. This is damage and scarred lung tissues from multiple possibilities. Thalassemia, which is a type of blood disorder again, and then type 1 diabetes mellitus. So what about individuals with FSH? I think that really the major complication in somebody with FSH muscular dystrophy is the risk is the respiratory involvement. So anybody who has involvement of their diaphragm or their chest wall muscles and has reduced lung capacity, and this occurs in roughly about 20% of individuals with FSH will have respiratory involvement. Again, the primary cause of increased risk for severe COVID-19 disease in individuals with FSH. And again, we talked about what percentage of people with FSH have problems with their lungs. And again, anyone with a lung capacity of less than 60% or less is considered to have significant lung disease. And those are individuals usually who are often using a BiPAP or CPAP or a trilogy machine, usually overnight when they're sleeping. Again, the other risk factors that are a result of weak chest wall muscles are individuals who have a weak cough, and such individuals are more susceptible to get lung infections, and they're also at risk of getting more severe COVID-19 disease. Again, the other consideration, as you all know, FSHD comes in it's not a uniform disease across all of the people who are affected. Some are affected more lightly and are very physically capable and active. Some individuals are more sedentary. And again, one of the things that I have to kind of impress upon everybody is that when you end up very sick with COVID-19 disease and you're in the intensive care unit, it is a situation where somebody's really in bed and not getting any physical therapy when they're severely ill. And somebody who starts with weak muscles, and even an individual who's not affected with the muscular dystrophy will end up being very weak at the end of that. And somebody who has muscular dystrophy, it's even worse. Being bedbound for a couple of weeks or 3 weeks or longer really takes a toll on your strength. It happens to everybody, but those individuals are more severely affected, will have a harder time, a longer time to regain the strength that they lost. Okay, so how to avoid getting infected if I have lung involvement? Again, strictly following the guidelines set for everyone, social distancing, working from home, avoiding large gatherings, use of face masks when outside the home, and frequent hand washing. And these are things that have been drilled into our minds, and sometimes we forget them by accident, but you really have to be vigilant to try to avoid getting infected. And again, for those who use BiPAP and CPAP or Trilogy machines, make sure anyone who comes to the house to service your machine is not sick and uses a face mask and gloves. And again, this is important because I'm assuming that some of you may need aides at home who come in and out to help you out. And that becomes a little bit problematic because these helpers, these aides who come in and out, may work at in different households, and that increases your risk of getting infected. And so you really have to be very careful. They have to be very careful when they come into the house to stay, to be gloved and gowned and have a mask. Okay, what if I'm sick and I have to go to the ER? Unless you think you might have COVID-19, avoid the emergency room and first seek advice from your physician. Most of the emergency room centers are going to be overloaded with patients. You don't want to go there thinking that you have COVID-19 when you have a common cold and get exposed to people who might have COVID-19. So first, call your physician and seek their advice. Make sure that you tell the ER physician that you have a muscular dystrophy called FSHD. They may not understand exactly what FSHD is, but just telling them that you have muscular dystrophy should alert them that you're at increased risk. And again, especially if you have reduced lung capacity, you have to make sure you tell them that. If you use a machine like a BiPAP, bring it with you to the emergency room because you'd rather use the one that they may not let you keep it. They may switch you to one from the hospital, but it's a good idea to bring it with you. And again, also have the doctor taking care of you, who's a neuromuscular disease expert. Let them know that you're there and have them be available for the emergency room doctor to talk to if they have any questions about your condition. So what if I had COVID-19? You have to remember that the majority of individuals who contract COVID-19 have mild to moderately severe disease and fully recover. There are no proven treatments for COVID-19 at this point. And I have to emphasize that point. All of the drugs that have been talked about as being useful, except for the use of dexamethasone, which is used in certain instances, in certain conditions with COVID. All of the other drugs have not been proven to work. And there was just a recent release from the World Health Organization, WHO, that all of the 4 drugs that were trialed in individuals with COVID-19 do not work. However, one of the big things that has happened since the last time we spoke is we now know much more about how to manage patients with COVID-19, and the outcomes are much improved. The length of stays in the ICU has diminished tremendously. There's decreased mortality among ICU patients, a significant decrease since 6 months ago. And again, this is due to the efforts of the medical staff, the doctors, and the nurses at the forefront of this battle, and the experience that they've learned over the last 9 months. And there are many things that they can do now that they know they should do that they didn't know about, that really has had a major effect on survival and shortened hospital and ICU stays. So it's been a long and exhausting year for all of us. You have to be patient and stay safe, protect yourself and others. There's light at the end of the tunnel. One more click, Ghinwa, please. Because there's COVID-19 vaccine at the end of that tunnel, and we're hoping that it's going to be available soon for the people at the front line and people in nursing homes. And in the next several months, it's going to be available for many more individuals. And we're all hoping that by the spring and into the early summer, most of everybody would be vaccinated. Thank you.
So next, I'd like to welcome Dr. Dumyati.
Thanks, Dr. Tawil. So I'll update you on the status of COVID-19, more epidemiology and prevention. And I think the tunnel, yes, there is a light at the end of the tunnel, but people said it's a long tunnel. We're almost there. We just have to, make sure that we keep ourselves safe. And I'm going to tell you kind of how to do that. So as of December 9, globally, we have around 68 million people with COVID-19. In the US, 15 million. The number of deaths also is high, around 1.5 million. In the US is around 290,000 patients. So compared to when I presented several months ago, this is a big increase in number of patients and death. And this is a graph, if you want to see it visually, of what's happening across multiple countries. And you could see the US, we have had a big jump in our cases starting early November. And I think Thanksgiving really did not help as well. And we're starting to see locally a lot of cases related to gathering during Thanksgiving. And this is a map that shows in the last 7 days, which state has the highest rate of COVID-19. The darker blue are the states with the higher number of cases. There is on the CDC website, or if you Google, you can find out by county what's the percent positive number of cases. And it gives you an idea of the prevalence of disease, especially if you are planning on traveling. It can give you kind of an idea that if you should or you should not go. And so going back, what did we learn about transmission? Not much has changed. The disease spread from person to person through close contact, mostly within 6 feet. And it's due to the fact that when we talk, when we sneeze, when we breathe, we spread, respiratory droplet or small particle. And then the person in front of us inhales those, or they land on your eyes or your mucous membranes. Transmission through contaminated objects is not really the main mode of transmission. What is making it very difficult to control this disease is the fact that people who are asymptomatic are infectious. We have learned also that in some situation, you could be more than 6 feet away and be infected. And this is more common in areas where there is a poor indoor ventilation, more in, where you sing, there's, people, when they sing, they kind of expel the droplet further away. In restaurant, because we're not masked, or fitness classes, because we're breathing very heavily. So I, for example, right now would not go and have any meal inside the restaurant. Outside should be okay, but I would avoid going into any inside the restaurant, even though the capacity has been reduced. It depends really how big the place, how good the ventilation is. out of precaution probably is not a good idea. So how can you protect yourself? Dr. Tawil already mentioned, I'll repeat it maybe. You still have to stay 6 feet away and you still have to wear a mask where you're in public. And I also suggest if you have people coming to your house to take care of you, that they should be masked, but you should be masked as well. That reduces also your, protects you as well. Washing your hand is important, especially if you go out. And so whenever I go out and come back, I always go immediately to the sink and wash my hand. It's also recommended not to travel, especially at this time where we have increases across the entire US. And try to keep it to your pod. And I think people have created a community of other people that are very careful and isolate themselves. And you could probably maybe more safely get together with them. But you have to make sure that you know where they're going and if they are careful and not exposing themselves to other people. And for wearing masks, it's very important to wear a mask the right way. I get very upset when I see people in the supermarket with the mask under their chin. The mask really to really be effective, it has to be covering both your nose and your mouth, not just under your nose. So it's very important that people wear it appropriately. Now, I was asked to address what can you do for getting together during the holiday. And I found this picture on Twitter, and I think this is the safest way to really have a holiday celebration this year, is to really not to get together with anyone, basically, especially with people that are traveling from other areas that have a high burden of disease. I don't think it's a very good idea to do it. There are some, advice on the CDC website, how it can be done safely. If you could eat outside, that's better than eating inside. I think the risk is really more when people are not masked. If you're masked, everyone is masked and you're 6 feet apart, the risk is much lower. If you're inside, it's recommended that you have the windows open, even put a fan so there is exchange of air and better circulation. So this is, I took from the CDC website. The safest way to celebrate winter holiday is to celebrate with people at home, with people that live with you. Staying home is the best way to protect yourself and others. Travel and gathering with family and friends who do not live with you can increase your chances of getting or spreading COVID-19 or the flu. And locally, we are aware of multiple gathering. It could be small, it could be 10 people. And this is what's really driving the increase these days in the small gathering of people for a birthday party or some other reason. Some of them might be inside, but intermittently people go, some of them are outside, but intermittently people go inside and they are not masked. And so we're seeing a lot of, healthcare worker, physician, across the community, a lot of those small gathering, increasing the burden of COVID in our area. So if you are planning to travel, or you have, CDC has a checklist trying to kind of evaluate the pros and cons of traveling. So where are you going? Who are you visiting? Is the area that you're going to has a high incidence of disease? Is your area with high incidence? When you get to another state, what do you have to do? Do you have to quarantine? Do you have to get tested? And then how are you going to get there? Are you going to drive alone? Are you going to take an airplane? And are you going to travel with people you don't live with? So the more exposure to people that are outside of your pod or what's called the bubble, the more it is risky these days, just because there's so much COVID around us. So I think the safest way is really to stay put and just gather with people you have live with you, or your people that are like you, safe, and that you see all the time. Is probably the safest way to celebrate the holidays this year. They have some ideas about virtual celebration on the CDC website, and I have a link. You could just link cdc.gov and then holidays, and then you could find all their advice regarding of how to celebrate safely in 2020. Now, I was also asked to address testing, who needs to be tested. There are different categories. So if you have symptoms of COVID, which is kind of anything ranging from a regular cold to fever and chills, some people have diarrhea, cough and shortness of breath are very important symptoms. You should contact your physician and get tested. And your physician can advise you where to go and get tested, or if you have mild disease, if you should not get tested, but just stay home. If positive, you need to stay home for at least 10 days and can come out after 10 days if you have resolution of your fever for at least 24 hours. If you have another reason why you might need to get tested, if you have a close contact with someone who has COVID, again, you should consult your physician, or usually what happens is the health department will call you because your contact informed them that they had contact with you. And if you get informed that you have contact with someone with COVID, the best thing you could do is don't go anywhere. You should isolate yourself, you should get tested, and you should not go around until you get the test result. A negative test, though, however, does not rule out COVID because it depends, it takes approximately 5 days for your test to be positive. So if you're tested too early, you might be negative, but 2 or 3 days later, you might be positive. So it is recommended that even if your test is negative early, to stay home. It used to be 14 days, but now the CDC has balanced the pros and cons of this long duration of what we call a quarantine. And they have other advice that you could probably come off at 7 days if your test is negative, or at 10 days. So they're trying to shorten this duration after the exposure. The states are also, and the local health department are also testing randomly people who are asymptomatic in certain area, just to assess the burden of disease and try to guide the mitigation to prevent, the transmission and decrease the burden of disease in some communities. And so as far as treatment, as Dr. Tawil said, there's really not many approved treatment. More recently, there were 2 treatments that were approved by the FDA under emergency use. And these are monoclonal antibodies, and they can only be used in outpatients who are not severely ill but have a high risk of severe disease. So you might qualify, and you should probably contact your doctor if you test positive for COVID-19. The issue with getting those monoclonal antibodies, they're giving intravenously through an IV. You have to be monitored during the 1 hour of infusion and 2 hours after. So the logistic of having this in place has been very difficult. And locally, for example, for us, we have not been able to administer this drug to outpatient or to people in the nursing home. But just know that this is available. We're not really sure, how effective this treatment is. We know that some people recover more quickly, but it doesn't really affect the long-term effects such as mortality. As Dr. Tawil mentioned, corticosteroids have been, kind of the workhorse these days, is what we use for people who are critically ill or severely ill. Remdesivir is another one. The WHO did not approve it because it does not change mortality. In the US, it is approved because it has been shown that people who receive this drug stay in the hospital for a shorter period of time. So that might help with a surge of cases. And that's why this drug is approved, but it's really kind of it's not a miracle drug, basically. And so what we really need is a vaccine to get us back to a normal life. There are many vaccines being tested. 2 vaccines will be approved in this week and probably next week. And CDC has set priority group to receive the vaccine because we have a short supply at the present time. And so the group that's going to go first is a group of the first phase, and the first 1A of this phase is the healthcare personnel, anyone who has contact with a patient. It could be someone in pharmacy, it could be an environmental service staff, it could be a nurse, it could be a doctor, and the long-term care resident. In New York State, for example, we're starting with a nursing home at the end of December. Once we're done with this phase, we will start the essential workers, and trying to figure out who goes first is quite complicated. There's a lot of planning by the federal government and the state, trying to kind of coordinate all this effort. Of note, the vaccine need to be kept on at very low temperatures. So that's kind of some of the challenges of using that for the two vaccines that are being improved in the near future. For you, you probably fit in the phase 1C, so adult with high-risk medical condition and adult that are above the age of 65 will be the third group, and it's going to be probably by, I guess by March, probably, or by the end of June. I guess people are saying that by the summer, everyone will be able to be vaccinated. So you will qualify to be vaccinated before the rest of the population because you have an underlying medical condition. There is a lot of questions about, the vaccine. The vaccines that are being approved are messenger and RNA vaccines, and they have been developed very quickly because there is a lot of research that was taking place before COVID appeared. This methodology has been used to in cancer treatment and so forth. So once the genetic material of the COVID-19 virus was identified, the company already by February had a potential vaccine in place, and they submitted their plan to move forward. Of note, the messenger RNA vaccine is kind of a genetic material that is taken from that virus. It's not the complete virus, so it cannot cause COVID-19 disease. What happens is this messenger RNA, I don't know if you can see on this picture, it's kind of the genetic material. It's put in something like a lipid envelope that is administered to you, and then your body will make a protein based on this messenger RNA, and the protein will produce something like the spikes that are on this virus. This is the SARS-CoV-2, and then our body will generate antibody to this virus. So if we're exposed, we are able to fight the disease. So these messenger RNA vaccine will not give you COVID-19, and there is a lot of misinformation. It will not change your genetic material. Once the mRNA is in you and there is production of the protein, it's gone. It doesn't replicate. Now, people are worried because, I don't want you to be the first person who is immunized, but for this vaccine, we have a lot of data of those two vaccines being used globally. Over 40,000 of people have been immunized with the Pfizer vaccine, over 25,000 with the Moderna vaccine. The people enrolled have been diverse. There are people who are Black and Hispanic, and there are people with comorbid illness and people that are above the age of 65 in those trial. And the interesting thing compared to the flu vaccine, the effectiveness of the vaccine is very good. It's kind of everyone is jumping in joy because they have seen after 2 doses that it protects 95% protection from disease. We don't know if it protects you from having asymptomatic disease where you can transmit it. So it's still recommended that even if someone is immunized, to still wear a mask, especially if there's limited people around that are vaccinated. And the very exciting news as well is that there is a similar efficacy by race, different ethnicity, and even in older individual. So it's a very good news. The vaccine is safe, and I think it's being reviewed today by the FDA, and hopefully it will be approved by tomorrow, at least the Pfizer vaccine. The Moderna vaccine will be reviewed on December 17. And once the vaccine is approved, it's going to be shipped to the state. And as I said, it's going to be given to the healthcare personnel and the resident of nursing home. The vaccine is probably, as far as reaction, is similar to the Shingrix vaccine or the herpes zoster vaccine, where some people can develop some injection site pain, or some have malaise, some have fever, but these are very short duration and people recover very quickly. And what we have learned, that it is good if you get those reactions because it means that your immune system is working and you're responding to the vaccine. And this is normal. And I guess this is all I have to say today, and we have time for questions.
Thank you so much. That was so informative, and thank you. So we have a few questions, so let me go to them right away. We have a question from Virginia. Do you advise individuals with FSHD to get the COVID vaccine?
Yes, definitely. When it's approved for people with underlying comorbidities, yes.
Okay.
And can I just say one more thing regarding the vaccine, which I did not mention, and it's a common question. If you had COVID, if someone had COVID, it's still recommended that you get vaccinated, because we don't know what's the long-term immunity from disease. So it's a very common question. If someone had COVID, it's still recommended that they get vaccinated.
Okay, great, thank you. There's a question: if FSH patients with reduced lung capacity, should they take the vaccine? I'm wondering if there's added risk of the vaccine itself, or
no, not at all, not at all. So most of the reactions are kind of fever, malaise. It should not really affect at all your lung capacity. It doesn't cause COVID because it's only very limited genetic material and the production of the protein that happens from it. So there's really no risk from affecting at all your lung capacity.
Okay, great, thank you. There's a question. We have two vaccines that may be approved soon: the Pfizer and then the Moderna. Is there any basis on which to choose one or the other?
They're very similar. They're very similar in their efficacy, as I showed you, and they're very similar in their side effect. And it's going to depend what is available. And so I would not favor one or the other. So what is available for you to receive, you should receive it. What is important is for the second dose, you should receive the same vaccine. So people have to keep track of what's the first dose of the vaccine, what type of the vaccine they receive. So the second dose is the same. And this is another challenge, is like you have to wait for the second dose to develop immunity. And people really need to take the 2 doses.
Mm-hmm. There's a question about how much time does it take from receiving the vaccine to be protected? Is it a matter of
2 weeks after the second dose? There is like 3 weeks between the first and the second dose. And so it's going to take people from the first dose till immunity.
Oops. Your sound faded out, but so basically, if you are able to get the vaccine, you can't let your guard down right away, right?
No,
you can't say a lot going.
You cannot, because also around you, many people are not vaccinated. So you probably need a very high percentage of people to be vaccinated around you so we can go back to normal.
Right. Okay, that's important. There's a question. You mentioned that in the 9 months since this pandemic really started, there have been new management techniques that have helped save lives. Can you tell us what those are?
We know now, when someone who is critically ill and short of breath, when do we need to put them on a mechanical ventilation and when should we wait? We have learned that positioning someone on mechanical ventilation on their, on their stomach really helps, has helped, and the steroid have been really, really very helpful. So we have learned a lot about, can we delay, intubation or mechanical ventilation? Can we use steroid, remdesivir? How to position the person? As we have learned a lot how to manage. I don't take primary care of people in critical conditions, so this is all I know of. There's probably more nuances that a critical care physician might be better fit to answer those questions.
It's a question asking if the vaccine has been tested in pediatric population and will it be available to the pediatric population?
It hasn't been tested for patients below the age of 16, but there are plans to have studies in the younger population.
Okay. And I think
it has not been studied also in pregnant women, which is kind of one of the issues that people are asking. But some of the volunteer in the studies became pregnant after receiving the vaccine. And so they're being monitored, and there is a registry for pregnant women that have been vaccinated. But so far, we haven't heard of any untoward side effects.
Okay. There's a question here from someone in the UK where they've been hearing that ivermectin is a treatment. Can you comment on that?
Yeah, I don't think the evidence is very strong. We're not really recommending it in the US. There is a lot of medications being tried, but so far we really don't have anything. I think the best thing we have is really the corticosteroids.
Mm-hmm. There's a question, I think you answered it already, but it's worth repeating. If someone has already had COVID, should they still take a vaccine?
Yeah, it is recommended to take the vaccine. If there is a shortage of it, you could wait a little bit in line. It's okay, but you still need it because we don't know if the immunity from having the disease is prolonged. We know from SARS-CoV-1 and MERS that the immunity might last a year or two, but not longer. Mm-hmm. And we also, if someone is interested, we don't know how long the immunity to the vaccine will last because we need the time to study it.
Mm-hmm. Does this mean that going forward we may all need to get a COVID-19 vaccine every year the same way we get a flu vaccine?
We don't know. We might. The difference between COVID and the flu is flu changes really every year. COVID so far has not changed dramatically, kind of the genetic makeup of it. So we're hopeful that we might not need to be re-immunized every year or every couple of years, but we don't know yet. We just have to wait and see.
Okay. This is a question maybe for Dr. Tawil from someone who says, I have been a full-time power wheelchair user for 10 years now. Does that level of immobility weaken my overall immune system?
No, it does not weaken the immune system. But again, as I mentioned, if somebody's has reduced muscle mass, a stay in the hospital because of COVID is going to make you much weaker. Also, I would be concerned, even if you don't have any symptoms, that if you're wheelchair dependent, that you might want to make sure that your lung capacity is not reduced.
Mm-hmm. Actually, related to that, are there things people with FSHD should be doing sort of prophylactically to avoid getting sick during these winter months? Not just from COVID, but just overall, health, and especially if they have pulmonary involvement.
Yeah, again, I think it's avoiding situations that make you sick. Even, you want to stay, again, if you have lung involvement, you want to stay away from anybody who is ill, even if they have a common cold.
Mm-hmm. And I suppose you should get a flu shot.
And the flu shot, yeah. That's a given. Again, that should be something that everybody should take.
Right. And if you have a weak cough, you be like using cough assist kind of regularly, prophylactically, to make sure?
So again, I mean, it depends on whether this is associated with a reduced lung capacity that may or may not require you, depending on how low your lung capacity is, to have a BiPAP or BiPAP machine, preferably. But there are devices called cough assist devices that in individuals in this condition that would help them clear their lungs more easily if they have a weak cough.
Okay, thank you. Here's a question from Wayne, who says there was some research in 2008 indicating that cytokine factors IL-4, IL-6, and NF-kappa B, etc., are associated with FSHD oxidative stress. Could this perhaps elevate the risk of a cytokine storm in the FSHD population?
That's a good question. I'm not sure I know the answer to that, but I mean, I don't think those findings were necessarily that from those findings that your risk of getting a cytokine storm is increased.
Okay. Thank you. We have a question from Jeff, who asks, do you know how many people, or do you know of people with FSHD who have contracted COVID-19 and what their side effects might have been?
Well, none of the patients I've followed have contracted COVID-19. We did do a survey nationally here of 600 patients with FSHD, and only 4 of them were affected, got COVID, basically.
Right. But that was back in April, early on, yes. It might be interesting to send out a new survey, because there might be many more who've contracted it.
I'm sure. I mean, by now, I think just about everybody in the country knows somebody close by who's been affected.
Here's a question from Rachel saying she saw a study regarding the use of melatonin. Are you aware of that study for, I guess, as a treatment for COVID-19?
I heard about it. I did not review it, so I'm not sure I can comment.
Okay.
There is a lot out there. You have to be careful. There is a lot of misinformation. Where I go for my information, CDC has a lot of information, but there is also infectious disease societies, like the Infectious Disease Society of America has guidelines, and anyone can access reviewing all the literature and saying this works, this doesn't work. WHO is another place where I would check for information.
Okay, great. Thank you. Here's a question. It says that in the UK, people with allergies should not get the vaccine. What is your opinion on that?
It's being reviewed today in the US, and so far as from the tweets that I have seen, they are not concerned. They have not seen much anaphylaxis in the vaccine studies, which involve thousands of people. So the thing that I think is good, knowing so quickly what is happening and kind of acting on it, this is exactly what we're going to do moving forward. So the fact that those 2 people were identified and the guidance in the UK change is great. This is what we need. We need transparency. We need information. In the US, I have not heard so far that it would be not used in people who have history due to anaphylaxis to other things. We'll wait and see, once the approval by the FDA happens, which probably will happen tomorrow.
Okay, great. There's a question regarding whether there are certain muscles that might be better to get your vaccination. I assume it's an intramuscular injection. And I suppose underlying part of that question might be the concern that if muscles become inflamed, that they might be maybe at risk of DUX4 related, DUX4 activation or so on.
It-
Do you have any?
So the deltoid, is that usually where it's given? Yeah. So the deltoid muscle in many individuals with FSH is usually preserved muscle. And it has a good muscle mass. So that shouldn't be a problem. I think if there is a very atrophied muscle, then they should probably look for another site. But it doesn't matter what site they choose, but any type of inflammation that happens from any type of injection is transient. It will go away. It's not going to cause long-term damage.
All right. Great. Thank you so much. Here's a question. Should people with FSHD monitor oxygen with a pulse oximeter?
Not unless you feel sick. I mean, I think that, again, so here's the thing. I mean, if even people who have low lung capacity because of a neuromuscular condition, their oxygen level is normal because there's nothing wrong with their lungs, so they can absorb the oxygen appropriately into their blood. So you're not going to get a problem unless you have an inflammation in the lung. And if you have an inflammation in the lung, you're symptomatic. You should be seen by somebody. So just randomly checking your oxygen level, it doesn't really help.
Okay. I had a question about what we've learned about early COVID symptoms, because so many of them seem kind of non-specific, like a fever or cough. But the one that seems a little more specific is this loss of taste and smell. Is there any data on how prevalent that is? I mean, is that?
It varies with the study. It's not, we hear a lot about it. You think 100% of people get it, but I think it's like 20 to 30%.
Okay.
And it varies with the studies. But it's something interesting because some people, it's the only symptom that they have. Someone woke up in the morning and went and got coffee and he couldn't smell it. And that was a hint to get tested.
Okay.
COVID.
So if you
when it's present, it's helpful.
If you can't smell the coffee, better.
If you can't smell the coffee, I think you should call your doctor and get tested.
Okay. Another thing I'm wondering if people have a better understanding of some of these longer term effects in people who have recovered from an acute COVID.
Yeah, it still needs more study to understand why it's happening and how much of it is due to COVID. But there is definitely some long-term fatigue. I know that some of the people I know have lost some of their hair. Some had insomnia, some had, brain fog. We don't really have a lot of knowledge yet, and it needs to be studied, and it's being studied. Long-term effect of COVID.
Okay.
And why does it happen, really?
Right. Thank you. It's a question from our Facebook audience. How long should you wait between getting a flu shot and a COVID shot? Should they be spaced apart?
That's a very good question. And to tell you the truth, I don't know the answer, but hopefully you got your flu vaccine already. And COVID vaccine will not be available for you probably until February or March. So I don't see, an overlap. And interesting enough, I have not seen discussion regarding this.
Okay. But I think the point there of you should go get your flu shot sooner than later is a good one.
Yeah, if you haven't gotten it yet, please go get it today or tomorrow. The nice thing about flu this year is we're not seeing a lot of cases yet, which is probably good because people are masking and staying away from each other. But it is really important to get vaccinated.
Okay. Another question, is it true that high vitamin D levels could be beneficial to avoid severe
There are some
COVID-19?
study that show that people whose low level, kind of at high risk of more severe disease, but there's no study that showed that if you get vitamin D replacement, it changes the outcome.
Okay.
So there's a lot of study about vitamin D for many, many diseases, but there's no study that if you replace someone's vitamin D, it will improve what's going to happen.
Okay, great. Well, we are at the end of our hour, so thank you so much, Dr. Tawil and Dr. Dumyati. We hope everybody out there stays safe. Beth, would you like to come back and make any closing announcements?
Sure. That was wonderful. Thank you, guys. So many answered questions that we've been bombarded actually all week from questions from our community. So this was really, really super helpful. We can refer everyone to this. We are recording this webinar. It will be available on the YouTube channel, on our Facebook page later. So if you want to review either what Dr. Tawil or Dumyati had said, you can find the videos there. But again, I just want to thank everyone for attending our FSHD University webinar today. Special thanks to our docs for taking the time to be with us today, for the great information and for answering all of our questions. Our next FSHDU webinar is next week on Thursday, the 17th. At our regular time, we're going back to 1 p.m. Eastern. Our guest speaker is actually going to be an orthotics and therapy expert. His name's Bob Meyer. He's going to speak about bracing for spine and knee issues, and will surely address other common issues among our FSHD community. So again, thank you very much for being with us today, and we'll see you next time. Bye, everybody. Thank you.
Bye.